5. We're so happy that you guys are able to join us again this week. For those that are new, welcome to the crew. And for those that are old, thank you guys for coming back. For those that are new with us today, this is Health Equity Month. April is, or you may see it as National Minority Health Month, but it's also Black Maternal Health Week, right? So either way it works because it's forcing us to really pay closer attention to the underserved and often underrepresented women and babies in our healthcare systems. And though the federal government is really focusing on COVID vaccination right now, especially with the J&J debacle, we wanted to make sure that we gave some time and attention to another very serious epidemic here, not only nationally, but even in South Carolina, and that's maternal and infant mortality among people of color. This is our second week of featuring our local experts to learn more about what they're doing and what we can do to improve the pregnancy, birth, and life outcomes for our mothers and babies of color. And we start these sessions with a brief overview of stats and facts, allow some time for our panelists to share their latest developments, interests, and findings, and then we will open the floor for question and answer, sending you guys back to work, hopefully feeling empowered to be brand new or revived advocates in this space, all right? This series is brought to you by the Roper St. Francis Women's Services Department and the Department of Community Health. Together, we honestly believe that we can empower every woman to take charge of their healthcare through the lifespan and offer high quality, comprehensive, equitable services customized to best fit your needs. And it is truly our daily mission to heal all people with compassion, faith, and excellence. So let's dive into week 2, what healthcare systems can do. Just a refresher from last week, maternal mortality is the death of a woman during pregnancy, at delivery, or soon after delivery. And according to the CDC, that's about 700 women a year due to pregnancy and birth complications. And honestly, they tell us that 2 out of 3 of these deaths are determined to be preventable. Infant mortality is the death of an infant before his or her first birthday. And are they first birthday? Look at me. And in 2018, we lost nearly 6 babies for every 1,000 that were born in the US, and that equates to over 20,000 babies in 1 year. So just to level set and refresh you guys on the things that we learned on last week. Now, infant mortality disparities have indeed widened over 170 years, y'all, which seems impossible given modern medicine. But for real, the gap between white and African-American infant mortality rates is greater today than it was in 1850. That's 15 years before the end of slavery. Researchers from Colgate University and The Ohio State concluded that in 1850, the infant mortality rate for Blacks was about 350 per 1,000 live births, and the estimated rate for white children was 217 per 1,000 births. Now, compared in 2016, provided by the CDC, the infant mortality rate for Blacks was 11.4 points per 1,000 births, and for whites, it was 4.9 per 1,000 births. So clearly those numbers are lower, but in 1850, Black babies were 1.6 times more likely to die in infancy compared to whites. And in 2016, our Black babies are 2.3 times more likely to die in infancy compared to their white peers. But there is a fuller story to tell, and this is actually a pretty good example of equality versus equity. Now, just based on those stats that I shared, we can see that there's a significant decline for both races, right? Less babies are dying, and that's certainly worth celebrating. We can attribute this to a wide range of public health and societal improvements. We have cleaner water, we have better dietary options, we have enhanced medical education and healthcare, technology, even clothing, guys, has proven to be a protective factor when we look at birth outcomes. However, these societal improvements were not always available or accessible for most people of color. Think about it. Segregation just ended in 1965. That was 57 years ago. We may have people on this call that's older than that and truly can remember this segregated South. And just to add insult to injury, Roper Hospital was one of the last hospitals in the country that admitted Black patients, and they were forced to do so by the federal government in 1969. Okay, so we are living in a historical context that we have to acknowledge and accept and understand in order to truly unpack this conundrum of a problem we're in. So while the infant mortality rates improved for all, it did not and is not improving at the same rate. So like the picture on the screen, we cannot give everyone the same bike and expect them to ride successfully. That's equality. We have to cater our services, our programs, and even our conversations to best meet the needs of each rider, or in our case, each mother. And that's equity and truly our ultimate goal. More stats. Did you know that compared to whites, Blacks and Hispanics received worse care for 40% of quality healthcare measures? The Agency for Healthcare Research and Quality publishes its National Healthcare Quality and Disparities Report every year. And in 2016, the measures within the report compared race, ethnicity in order to show those disparities that exist between the groups, right? Well, compared to whites, Blacks and Hispanics received worse care compared to whites for over 39% of the quality measures. And in 2019, that number remained consistent. And unfortunately, this distorts the perception of healthcare in the minds of those patients. Imagine the patients that actually receive that poor care and how they then tell those stories to their social networks, to their families and their friends and their own children. And these hospital metrics were outside of pregnancy. They were metrics related to asthma, diabetes, HIV, stroke, cancer, sepsis, all of the metrics you can think of that we capture in the hospital. And then also to add a bit more layer, we also learned that Black infants that are cared for by Black physicians have better outcomes, unfortunately. And why am I saying unfortunate? Because y'all, only 11% of our obstetricians in the US are Black and 7% are Latinx. Certainly not enough to manage a full population of pregnant mothers. Yet, compared with other specialists, OBGYNs had the highest proportion of underrepresented minorities. And these underrepresented minorities tend to go back to those impoverished communities or those federally qualified underserved areas. So if anything can be done, I am hopeful that it can and should start in this field with our babies and our mothers, because the OBGYNs seem to be headed in the right direction. And this article that you see on the screen was published in September 2020 in the Proceedings of the National Academy of Sciences in the US. So it's an actual journal article that I can forward out to you guys if you're interested. So infant mortality is often associated with premature births, even low birth weights. And we know that Black mothers are more likely than white mothers to be impoverished, very young and unmarried. These factors are often associated with higher infant deaths, and they're twice as likely as whites to have received late or no prenatal care. But research also tells us that a gap in low birth weight exists even when Black and white mothers are matched for age, marital status, education, prenatal care, and the father's education. A growing body of research points to racial discrimination or racism as a cause of mortality disparities for our moms and babies. The theory is that the repeated exposure to discrimination and microaggressions can have a stress-related weathering, they call it, effect on mothers of color, producing those poor pregnancy results and even infant death. Hence, it's very important that healthcare systems consider the factors that we can directly control to improve these disparaging statistics. So I offer these on the screen. First, access to health insurance. Are we connecting uninsured patients to assistance programs like Access Health? What type of financial counseling or social support navigation is offered in these practices? Two, access to prenatal care and primary care. Where are our access points to care? Have we considered rural areas with limited transportation options? What are our hours? Can patients visit in the evenings if they have a day shift job? Three, healthcare training and workforce accountability. Are physicians within the system aware that these maternal and infant disparities exist? Are there metrics or even accountability report cards reviewed routinely by the staff and the administration? 4, hire diverse staff. What's the demographic of your staff from the front to the providers? Does it represent our community or even the patient population that you serve? 5, patient-centered care. Are we building practices that keep the patient first, or are we focused more on our process and efficiency? Are we building in time to listen and connect during this very crucial time for many moms? And then lastly, cultural sensitivity and humility. Have staff been given the opportunity to participate in ongoing conversations like these about race and health and other cultural sensitivity trainings? But we also have to empower our pregnant mothers, especially mothers of color, to ask some of these tough questions. And here are some that I came up with. What's my risk for preeclampsia and other complications? What should I do if I think I'm having a miscarriage? What's my risk of preterm labor or pregnancy loss? How are doctors in this practice overcoming implicit bias to ensure success? And how can we work together? Because that's really what it's about, to overcome the current Black maternal mortality statistics. So tough questions, and those that don't come naturally to lay people, but those are things that we have to start encouraging our patients to ask. And then lastly, I wanted to show you guys that some resources that we have available. The American Hospital Association has a Better Health for Mothers and Babies initiative, and they've taken on the goal of eliminating maternal mortality and reducing that severe morbidity through this initiative. And as a part of it, they've developed various resources. So if you're interested, please visit their website to learn more. And then here locally, shout out to DHHS, the South Carolina Birth Outcomes Initiative. It's a wide-ranging collaborative that convenes not only DHHS, but the Hospital Association here in South Carolina. DHEC is there, all 45 of South Carolina's birthing hospitals, Blue Cross Blue Shield, South Carolina ACOG, March of Dimes, Neonatology Consortium, and even the South Carolina OBGYN Society. They all come together routinely to address these issues. And so kudos. If you are a data geek like me, they have this cool interactive dashboard where you can plug in numbers and really figure out what's going on in your area. So shout out to that team. Cynthia said, my son works for the South Carolina Hospital Association. They are doing great work, Cynthia. Kudos to you, because you raised them, right? And then Dr. Foster, he says, we need to look at the overall improvements in infant outcomes driven by technology, clinical improvements versus the inequitable improvements related to social, economic, environmental factors, including systemic racism. Absolutely, Dr. Foster. We cannot negate the impact of the social determinants of health. And we're actually going to dive deeper into that next week when we talk about what communities can do. Capricia sharing that White House proclamation that was issued yesterday. Yeah, shout out to the Biden administration. But if you're interested in what was shared, please visit that link in the chat box. So guys, I will be quiet and yield the floor to the people that you really came to listen to. Today we have Dr. Monica Mitchum, who's an OBGYN with Charleston OBGYN. And then we have Ms. Gabriella Brown. She's an RN and educational consultant for Peace of Mind Pregnancy. So I will stop sharing and I will pass the floor over to Dr. Mitchum.
Right. Hi, everybody. My name is Monica Mitchum, as she said. I'm one of the physicians at Charleston OBGYN. And first of all, thank you so much for having me. I'm honored to be, included amongst the leaders in the field in this topic. And I am in no way an expert in this topic, but I'm really passionate about it. And I'm constantly wanting to grow and to learn. And so thank you for having me. A little background about me. I was born in Charleston. I actually born at Trident Hospital. And then I went off to University of South Carolina for my education, undergrad and med school, and then all the way out to Houston, Texas, where I trained at Baylor College of Medicine for my residency. But my first experience with racial inequity in healthcare actually goes way back in the late 90s when my grandfather, who was Spanish speaking only, ended up dying in some unfavorable conditions in a hospital in South Texas. And my family just really felt that there was just not a lot of communication, not a lot of resources or treatment options for him. And so experiencing that from kind of the Latina side of things. And then in residency, the vast majority of my patients were Black women, women of color, brown women in Houston. And so when I was there, Texas was actually specifically kind of reporting all of their data about the increase in Black women and maternal mortality. And so that was about almost a decade ago, and we haven't made any progress in this. And so we really, obviously this is a very important topic, and I'm happy to present today. So I'm going to share my screen here so we can get going with, I have a couple slides for you guys as well. Share. Okay, can everybody see my screen now? Yes, okay, great. There we go. Okay, so why does this matter? These statistics have been presented a few times, but why is this lecture series important? Why are we talking about this right now? And I think all of us are pretty well versed in this, but the United States is the most dangerous place out of all the developed nations to give birth. And that, when it comes to Black mothers, that's 3 to 4 times higher risk of maternal mortality. And that is completely unacceptable. As healthcare providers caring for Black women, brown women, women of color, it is upon us to make a change, even if it's just individual or we're talking to lawmakers or working on policy, but we have to work to change these statistics. It can seem very daunting and overwhelming when you look at how to change this as one individual, because it is such a complicated problem and a very complicated system. With healthcare system as a whole, we're going to have to work on, Medicaid expansion. I know that was mentioned last week. The US is one of the only developed nations that healthcare is influenced by the market and by market forces instead of considering it a basic human right, which is a big deal. But what I've been tasked with discussing today is really provider factors, what we can improve on in our current care, and patient-centered care. So a couple ways to improve our existing practices. I think that number one, hands down, we need to raise awareness. A lot of our colleagues and peers, providers in this field don't even know about these disparities. And so talking about it, doing things like this, Every Mother Counts walk, that was really great, but raising awareness about this problem, number one. And then if you see something, a behavior, or you hear somebody talking negatively about a patient and you think it's race-driven, then I would say something. I encourage you guys to speak up. It does not have to be confrontational. It can be something as, this patient, oh, she had so many questions. Well, did you know that in the US, she's 4 times more likely to die from maternal mortality? So I bet she's really scared. And just make them think a little bit. You don't have to flat out say, I think you're being, racist. You can just say, hey, an open-ended question to just get them thinking about that attitude that they might have had. And then the second thing, and kind of tying into that, is identifying these implicit biases. Also discussed last week a little bit, but for those of you who don't know, implicit bias is completely subconscious. It's these rapid judgments and attitudes that we might have about a patient that kind of arises from our own experience and background. But, it's the huge threat to equal care because we don't know we're even doing some of the things we might do. The SMFM released a survey that showed 80% of providers thought that implicit bias affected their practice, but only 30% of them thought it was their own bias. And so that needs to be addressed clearly. And then lastly, optimizing communication and cultural sensitivity. This can be done with personal education, seeking out documentaries or articles and reading yourself, with peer discussion, or with training, in the hospital system. So there's no gold standard to identifying bias, but Harvard does have this implicit association test, and you can do it for race, ethnicity, gender, BMI. You can do it for a lot of different biases, but it is a widely accepted tool that you can use to kind of approximate your unconscious bias. And then I think all providers should do this. Self-assessment. This isn't published data. Nobody's going to know your results, and you can do it and then see what it shows. It's very surprising to a lot of people. It's very unsettling to a lot of people, but I think that is kind of the point, So after you identify these biases, what do you do? How do you fix it? So mitigation of bias, there's a lot of different strategies. Clinical preparation, these are the strategy-based responses. So find one you like that you can use reliably, whether that be stereotype replacement, counter stereotypic imagining. You can kind of research some of these, or we can go over them after the talk, but these are 5 different ways that you can mitigate your own bias. Medical education, I agree with Dr. Gleaton from last week, and she said she thinks she had like 1 class about cultural sensitivity and bias, and I agree. I think we had maybe 1 class in medical school. I never took any classes in college, never talked about it in high school, never talked about it, in residency really. So that should be pretty persistent in our medical education, nursing school, PA school. We should all, have these classes and continued education even afterwards. And then lastly, I think to help mitigate the bias is asking patients about their experiences. In the last year, in this pregnancy, have you ever felt your care was different than somebody else because of your race? Have you felt disrespected? Have you trusted your provider? Asking them about their personal experience is really important, and to listen to them. The average time it takes for a provider to interrupt someone is 15 seconds. So we don't listen to what our patients are saying a lot of times because we have 40 patients on the schedule, we have surgery at lunch, but you have to sit down and actually listen. So I came up with just a few scenarios to kind of just see how easy it can be to just brush someone off. But a 30-year-old Latinx female comes in for her 32-week prenatal care visit. She's been diagnosed with gestational diabetes, but she either hasn't been checking her blood sugars or her sugars are really high. And so stereotype can just say, well, she's non-compliant. She doesn't care about this baby. But what we should be asking is, did she fill her prescriptions? Did she get her glucometer? If she didn't, why didn't she? Could she not afford it? Could she not get transportation to the pharmacy? What were the pharmacy hours? Does she work 2 jobs and she could just not get there when they were open? The language barrier, does she understand what you're trying to tell her to do? Does she live in a food desert if her sugars are high? What are her staples at home? For so many of my patients in Houston, they made a huge meal with tortillas and rice and all of this for their family, and they had a lot of extended family living with them, and they weren't going to cook chicken and vegetables for themselves, or they just didn't have that in the home. And then Ramadan just started, so you have to ask about religious fast, is that going to affect their glycemic control as well? And be culturally sensitive to that. Don't tell them, well, you have to eat because of your baby. You have to find a way to make it work. We tell a lot of our patients to walk after dinner, 30 minutes after dinner. Well, is that safe for her to walk outside in her neighborhood after dinner? Does she have a safe place to exercise? And does she know of the resources available in the community if she needs them? Another quick example, 25-year-old Black female comes in for her 35-week prenatal care visit, but she's had a 12-week gap in prenatal care. Again, we can just turn a shoulder and say she just didn't care, she didn't want to come, but you have to ask her why. Why wasn't she coming? Does she not trust the provider? Was she having transportation issues, some violence at home? If you turn your back on her and just don't understand why, then the health outcome for her and that baby could be a lot worse. And so just sit down and talk to her about it. DHEC has a really good directory of services for women and families in South Carolina. It's 200 pages, and Charleston specifically has like 13 pages of resources from legal, counseling, substance abuse, job searches, childcare. So I also encourage patients that need that to look into this directory. To now move on from bias to focusing on patient-centered care, historically, the doctor walked in, did their spiel, but really we need to start talking to our patients about patient-centered care and letting them kind of dictate the plan, obviously still with safe care, but patient-centered care medicine says it takes into consideration patients' preferences, cultural traditions, families, values, beliefs, and lets them be an advocate for their own health. If they are an advocate for their health, they're going to be more compliant with their medication, documenting blood pressures. I think one of the easiest ways to even just start doing this is when you come into a room to sit down, and I usually ask, is there anything you want to focus on today? Normally at this visit, I might give a spiel about the glucose test, but before I even start that, I say, what do you want to focus on today? What are your concerns? And I did that with a patient recently, and she flat out said, how are you going to prevent me from dying from preeclampsia? Because she had preeclampsia in her first pregnancy, and she's seen the news reports. And that is her biggest fear. And so we had a wonderful, beautiful discussion. And I think that our physician-patient relationship has grown tremendously from that. And then to touch briefly on individual versus group prenatal care, I know a lot of you guys are starting up with centering pregnancy, and that's one specific model for group prenatal care, but it does show high levels of patient satisfaction. Patients feel more prepared for labor and delivery, higher rates of breastfeeding, lower risk of preterm birth, and particularly for Black women. And so patient-centered, whether that be individual or when you're doing it in a group setting, still focusing on the patient's needs is really important. And lastly, just empowered women empower other women. So I know Gabby's going to talk now and focusing on empowering women, especially women of color, to be experts in their own bodies and advocates for their own health. And so I think I'll just segue into that for Gabby here. And that's my little guy. All right. Thank you, guys.
Thank you so much, Dr. Mitchell. So my name is Gabriella, also called Gabby, more commonly go by Gabby. I'm just going to tell you a little bit about myself. I graduated from the University of South Carolina with my Bachelor of Science in Nursing. And all I've ever really known is labor and delivery and women's services. I started that out as soon as I graduated from nursing school. I started my career out in Decatur, Georgia, at a high-risk, high patient acuity hospital, gained a ton of experience on that labor and delivery unit. Then after about maybe like a year and a half, I came back home to Charleston and worked at Roper St. Francis on the labor and delivery units. And eventually I got cross-trained into the nursery and then transitioned into a float nurse where I had the ability to work in labor and delivery, the level 2 nursery, and also mother, baby, and GYN. So after doing that for a while, I decided to do a little something else and started venturing into education. So I took a job as a practical nursing instructor, and I fell in love with mentoring and becoming a role model for students. After teaching for a while, I got the idea to start my own coaching course to educate women, and it's called Peace of Mind Pregnancy. It's a 6-week course, comprised of 10 modules, weekly coaching sessions, and the ability to become a part of a community of women going through the same experiences. And the great part about this with, COVID-19, it's totally virtual, so you can do it from the comfort of your own home. So the drive behind creating this course, I was seeing, all in the media, the rise in the maternal mortality rate in African-American women and minority women. As we said before, Black women are 3 times more likely to die from pregnancy-related complications than other races. And being a labor and delivery nurse and African-American woman myself, that really just, it saddened me so much. And it really, it tugged on my heartstrings. And I'm like, what can I do about this? There's something that I can do about this. So this is directly related to my community and my career, my passion. So I figured what better way to contributing to changing this narrative by combining my nursing experience and my teaching experience and delivering it to women who can really benefit from this information. I truly believe that being a fully informed patient is the foundation to becoming an empowered patient. Patients can make informed decisions with reputable information and become a part of the healthcare team rather than just going with the flow and almost being oblivious to what's going on. Knowledge is really power, and it can be used to protect yourself and to advocate for yourself if you ever feel something isn't right. You know your body better than anyone else, and you must be your own advocate. And it could potentially save your life and your baby's life potentially. Just some tidbits. It's okay to interview your doctor. You can sit down and ask your doctor questions. Also let your doctor know your beliefs and wishes. And you also may ask theirs. Some red flags. If you're with your doctor, maybe, they can't remember vital pieces of information about your health history, or you feel that your concerns aren't being validated. Those are some big red flags. Or maybe you just feel like you're a number. Just having a good relationship with your doctor is key. There should be a mutual respect for one another. You should always feel comfortable asking your doctor any question. No question you should never feel like a question is a dumb question. Some questions that you might want to ask your doctor, and I think we've gone over some of these, but how much bleeding is too much bleeding? I see patients all the time, or I get people in the community ask me, like, what is spotting? Or is this too much bleeding? Or, is it normal? Or is this really something that I should be worried about? You should have that conversation to know when there is complications. Also, hypertension, high blood pressure is very common in the African American community. Ask your doctor, what are the signs that you should be looking out for in relation to having preeclampsia and having high blood pressure? You should definitely know those and be on the lookout for them yourself. I think the most important questions that patients should be asking their doctors are, yeah, I can look out for the signs and symptoms as well, but what can I do to prevent these and be proactive and try to get ahead? So just more primary prevention, so we can start to see a decrease in some morbidities. What else? Let's see. Also, I think we talked about this too, but ask your doctor, are you aware of the issues that Black women are going through in healthcare right now? Ask them what their beliefs are toward this matter and if they're doing anything to make it better. That's all for me. So mainly I just focus on, patients being empowered themselves and educating themselves so they can be just a part of the healthcare team, making informed decisions, advocating and protecting yourself during your pregnancy, before, during, and after, really.
Thank you, Gabby. That's such an important part of this entire paradigm. In fact, I pulled up a quote that I had on my phone just listening to you and Dr. Mitchum that says, I diagnosed abdominal pain when the real problem was hunger. I mislabeled the hopelessness of long-term unemployment as depression. I misdiagnosed poverty that causes patients to miss pills or appointments as non-compliance. I mistook the inability of an older patient to read for dementia. But it really goes back to making sure that we're asking those questions, like Dr. Mitchum said, as the provider, but then Gabby, as you mentioned, empowering the patient to offer that context and to ask those questions of their provider. So thank you guys so much. I think that was a great compliment that you guys provided. Now it's time for us to ask some questions, and I jot some down myself. And if you want to come off mute, if you guys have a question, you're free to do so, or you can add it to the chat box and I will pose it to our panelists. All right. Well, I'll kick off with one while you guys deliberate. So Dr. Mitchum, you talked about centering pregnancy, and I've heard a lot of good stuff about it, but haven't really seen it in practice. this might be, well, I'm not having any more babies, point blank, period. But if I were, how cool would it be to, if I had friends or at least a network of women who were pregnant with me, could you initiate that yourself, or does it have to be initiated by the provider?
Yeah, that's a great question. So different groups offer centering pregnancy. The centering pregnancy model is a specific model for group prenatal care, but group prenatal care in general can be offered by your practice without necessarily using the centering. Although centering is, a very good curriculum. It's, well, a lot of great training. And so I know MUSC right now offers it. I think Dr. Gleaton is going to be offering it, and physician partners are getting grants to do it, because in starting up centering pregnancy, although there is no healthcare cost difference in the long run, starting that program can be quite cost prohibitive for an individual or for a private practice. But overall, yes, so it's, when you go to a practice, you can ask, do you only do individual prenatal care, or do you have any group prenatal care? What kind of curriculum do you have? And then see, usually you get enrolled in your first trimester along with other women that are also the same gestational age. And that's the whole point of it. You guys are all going through this pregnancy together. You're meeting at the times when certain topics should be discussed. And so sitting down with 12 women in a room for 90 minutes, spending all of that time with your provider and with a nurse and other people asking questions is really helpful, because somebody may ask a question that you didn't even think to ask. And then you have this open dialogue and discussion while still getting the individual checkups. You're still getting your blood pressure checked. Your urine is dipped. Someone's still measuring your fundal height. And a lot of times women are doing it with each other. So they'll check the heartbeat and they'll write it down in their book, but you're also documenting it yourself from a clinical standpoint. But they're writing their blood pressures down, keeping a log themselves, so when they go home, they can review their own, record. And it just helps, when afterwards, we did this when I was in Greenville in medical school. I was part of a group that did centering, and you stood around afterwards and they had lemonade and water and snacks. And, you got to really talk to people. Then focusing on breastfeeding, who has tried to breastfeed before, what were their, hurdles they had to jump through, and being prepared for that, because breastfeeding can be one of the most difficult things you ever do in your life. I mean, it's tough. It's challenging if you have a baby that doesn't want to latch or you're not producing enough. And then afterwards, those women have each other for support with infants. And so postpartum depression, they have people to lean on, they can talk to, they can call when they have issues. Someone else can say, hey, I'm worried about you, because they have moms that are going through the same thing as them. So they're centering parenting with pediatricians. So that's similar, that after the baby is out, you can graduate to kind of a centering parenting group. But I think asking your doc or your office if they do provide any group prenatal care.
That sounds awesome. And I can imagine how rewarding that would be for first-time moms, our moms going through a really complicated pregnancy.
Now, when you become high-risk pregnancy, you may have to have additional visits apart from your centering visits. If you still want to continue centering, that's fine. But any sort of high-risk visits would then be additional prenatal care. So you may have even kind of a combo of individual and group prenatal care.
Nice.
Usually it's like 10 visits, 90 minutes each for the group prenatal care.
Take away the pregnancy, add some mimosas. That sounds like brunch, Doctor. Sounds awesome. Sounds awesome. Dr. Foster.
Hey, how's everybody? Another wonderful presentation. Thanks to you and the two speakers. Just to add to the centering pregnancy, we do have a lot of experience in South Carolina. I've been involved with the Birth Outcomes Initiative since the beginning. And one of the interesting things, especially in Greenville, where they have the most experience, we have seen some pretty amazing results where they've actually been able to, in some cases, eliminate the gap in preterm births, low birth weight between Black and white babies. And it's correct that there are other ways you can approach, group prenatal care. I will say that I don't know where it stands now, but for some time period, HHS, Medicaid agency, was providing some funding to help practices start up. And definitely Blue Cross Blue Shield and Medicaid and the MCOs should still be paying a little bit of an adjusted rate for doing the care that includes the centering component. So it clearly is an example, though, something I put in the chat box earlier, is that And I want to go back to your initial kind of comments on the data, where we still have as much of an equity gap as we've had for well over 100 years, is that so much of our advancements as far as kind of universal advancements have been technology driven. So we've gotten better at clinical care. We've gotten better with technology, including what happens in neonatal intensive care units. We're saving a lot of babies that would have died before. But where we still have the greatest equity gaps is we've not had equitable improvements in the social, environmental, economic factors that include systemic racism. And the whole issue about that you also brought up about Black women have better outcomes when they see Black physicians, it continues to be very concerning, because, as you said, we don't have enough physicians of color available. And the reason why there's a difference is that, unfortunately, so many of the white physicians are faced with implicit bias and other factors that get in the way. In this past year, I've dealt with several cases of African-American women, some I've directly been involved in looking at these, seeing white physicians where it's just obvious racism-driven responses. In some cases, we've been able to get them to different clinicians, but I think it's something we need to think about how we do the training. The last thing I want to say is that there was a legislative effort to try to create the requirements for implicit bias and cultural awareness training in that maternal child space at hospitals. It's been modified to look at a study committee on how we would best approach this. And I'm hoping that at least the study committee will pass, because we've got to find a better way for dealing with this, because it needs to be included for all clinicians in training, because there's not enough of that occurring, I don't believe. I'll let the other speakers address this, but also for our existing healthcare workforce, is we've got to find ways to create more awareness that we are doing things, sometimes implicit, but sometimes explicit, that are causing more risk for moms and babies. So it's not the clinical issues. In fact, centering pregnancy doesn't really, for the most part, change the clinical care. It's changing the social and support and educational environment for these moms and producing significant improvements in outcomes. So I'm just so glad that we're having this dialogue. And I think that understanding where we can actually make the most difference in the health systems is going to be really important.
Thank you, Dr. Foster. You're absolutely right. We got to start with education, not only in med school, but also in practice. Crystal Davis added to the chat box. She loved Dr. Mitchum's presentation. And Gabriella, she said, your course is awesome. Can't wait to learn more about it. She was wondering how you fit the childbirth education into the centering pregnancy model.
Yeah, so each week you'll go throughout a couple of modules yourself. So it's like a self-paced thing. And then at the end of the week, usually on Sunday nights, we'll get together as a group and I'll address any questions. And each module, all the modules that go from pregnancy to labor and delivery, childbirth, postpartum, and even some newborn care. So each week we'll kind of group together, and that's the opportunity to ask your questions. And that's really the meat of the course, is when we get to meet and you ask your questions from the modules and just expound on the information. So that's kind of where the pregnancy centering comes in. I hope I answered your question.
It sounds like your course is really comprehensive, like in
Yes.
that it's a lot of prenatal information and education, but you're also getting that childbirth education.
Yes,
so it
most
sounds
definitely.
like you wouldn't need like an additional course.
It's definitely comprehensive. We're going to talk about pregnancy. We're going to go through the trimesters. We're going to talk about childbirth and labor and delivery, the whole process, and also postpartum care. If you have a C-section, or if you have a vaginal delivery, whatever your case may be, we're going to go through all of that. So the idea is for you to have a peace of mind going through your pregnancy, so that, I know especially a lot of first-time moms have a lot of anxiety, and they just, they're just like, I don't know. So I try to ease your mind by going through all the modules and meeting with you every week to try to guide you and coach you kind of through your pregnancy, so that you'll feel more prepared.
Gabby, could you please add your contact information to the
chat? Oh, sure, I definitely can.
Send it out to that listserv as well, with the contact information for all of our panelists, because you guys are hot stuff.
Yes.
Dr. Mitchum, Mandy, you had another question?
No, I was just going to make a point in that one of the things that as healthcare providers that, and Dr. Mitchum has touched on this, particularly, you know, as white healthcare providers, is not to envision the empowered Black woman as an angry woman, right? Like, I think so often, you know, when really any woman, but I tend to see it more with Black women, anytime they say no or have questions or want more information, you know, they're seen as, you know,
Aggressive.
Yes, aggressive. Thank you. That's, I was trying to find the words. Right, right. And, you know, I think then that automatically puts up a barrier because you're not responding. I mean, that's it. Dr. Mitchum said, well, there's a reason why they're this way, right? What is that reason? And getting down and getting to know their history and you know, clearly there's some discomfort in what's happening and so on. So there's just a point.
Yeah, thank you for adding that, Mandy. You're absolutely right that those past experiences could certainly affect how you engage with healthcare providers and even how you may mute yourself when you engage with providers. Sarah Covington, she has a question.
Yeah, I appreciate the clinical point of view this week. So, and I've been thinking about something. I've been thinking about when I hear about African-American women that had close calls, right? Like, you know, it could have been a terrible situation. And, you know, like with Serena Williams or, you know, some of the cases that we've had here in South Carolina, what we hear from the moms is, I wasn't listened to, I wasn't heard. You didn't listen to me. You didn't pay attention. You didn't believe me when I told you something. And then I think about that video that y'all showed last week, and it showed the clinician just totally ignoring the patient's concerns about the pain that she was having. And I remember working in the prenatal care space, and how many times a day, Dr. Mitchum and Gabby, do you have to answer that daggum round ligament pain question? And every single woman individually thinks that round ligament pain is going to murder her and she is dying, right? But it's just round ligament pain. But you also can't just say it's just round ligament pain because, right, you want the patient to be heard. So there's that like stressful dynamic between listening and respecting to the patient, right? And not tossing off her concerns as not a concern, but also, you know, you've got 18 patients, all that have round ligament pain waiting in your waiting room for you, right? Like, but some of it is just the art and the skill of listening and communicating respectfully. And is that part of the space for medical education and skills building for clinicians? I just wanted to explore that and hear what you think about that.
I think that's, you know, kind of what the point I was alluding to earlier is, it takes us 15 seconds on average to interrupt a patient. 15 seconds, you know, and if we just let them describe that pain a little bit more, we can say, okay, well, these are the warning signs, you know, these are what I'd really be concerned about. Pain that doesn't go away when you rest, bleeding associated with pain, not feeling your baby move as much, you know, and always, you know, offer, if I have a patient that is just persistent, like something is definitely wrong, you know, I'll offer a bedside ultrasound, you know, show them the placenta, show them the baby real quick, you know, and just give them that peace of mind. But, and I do think I thought I was empathetic before, but having gone through a pregnancy now, I am way more empathetic, having had those round ligament pains and the lightning pains. And you're like, oh, I get it. Like you think you're 100% in preterm labor or dying, but yeah, it's so intense. And so I definitely can say now to a patient, well, yeah, I get it. You know, I feel that, I felt that pain before too. I know it can be scary. And I think that's also reassuring. And a lot of our male providers can't maybe offer that, but I think that can give more peace of mind to patients as well. But if they are persistent, that they keep having this pain, it's something to look into, you know, definitely listening to patients' concerns and why they're so concerned and what fears they have, for sure. We had I'll never forget my July 31st of 2013. I had a maternal death in Houston from a postpartum hemorrhage with DIC, and this husband standing in the hallway with his newborn and his toddler. And, you know, they're like 8 and 10 now. And I think about those boys all the time. And, you know, that woman's concerns weren't heard. I came on a night shift and she'd already delivered, but she was in DIC. And that plays over in my mind all the time, that scenario. And so taught me to be a much better listener as far as when patients are worried, when they don't feel right, when they just have a funny feeling upstairs in the postpartum unit, just go to their bedside, just do an exam. You know, it takes 5 minutes, and just going and reassuring them if anything. Or you might find something. You might have the nurse come take their vitals and actually be something really concerning.
So Kim, can I quickly come back to the recommendation about the questions being asked? I think that's really important. And so we probably need to figure out ways to help more women, including African-American women, women of color, the questions they should be asking their OB care provider even when they first see them. To me, the challenge is going to be, I think in many cases, if you have the right set of questions, you're going to be able to tell pretty quickly in many cases if there's going to be a challenge. Where I think health systems need to think about what they need to do, since so many of OB care providers, if not employed by the hospital systems, are closely affiliated. How do you respond to that woman and her family if they say, I've got some concerns, what do I do now? Right. And so there are going to be times when you don't know. And unfortunately, like you were just describing, that can happen, you know, at the end of the pregnancy, you know, around the peripartum time. But I think we've got to be prepared for encouraging women to ask those questions. And then if they don't feel comfortable, if we don't give them alternatives, we're basically telling to them, sorry, you just have to deal with it. And so this is where systems, I think, need to think about what role the system plays. At the same time, we need to be educating the individual practitioners.
Absolutely. It's a both and. And so we've been recording these sessions so that we can gather all these notes and come up with whatever product, tool, resources that need to come from it, because this isn't just about static conversation or static noise for this week. We want to make sure that these conversations have legs. And so thank you guys. Janice just shared her personal experience has been bias and negative patient-provider interactions and how that has a cumulative effect on the pregnancy and even future pregnancies. And you're absolutely right, Janice. So how do we start to turn the ship? And so I really want to say thank you. I know we have 3 minutes left, to Dr. Mitchum and to Gabby for sharing their services and resources. I'll make sure to send out their contact information. Gabby added hers to the chat. But Dr. Mitchum, please know that patient did not die in vain, because we can feel your passion through the screen. And Gabby, you also are palpable. So thank you, ladies, for what you do and what you contribute to the world. And I'm going to leave with #BelieveWomen. All right. So hopefully we will see you guys next week when we come back to talk about what communities can do in this space. We'll have Dr. Reshma Khan, who's working at the Shifa Clinic. We'll have a doula on site as well. And I believe that we'll dig deeper into those social determinants of health and how the community plays a part in these birth outcomes. But thank you guys so much. And I hope that you enjoy the rest of your week. Go forth and continue to be great. Let's save the world, people.